Assalamu alaikum. Now, let's dive into the PNH, paroxysmal nocturnal hemoglobinuria. Before jumping into PNH, first hear this murmur. Can you tell me the name of this murmur? Now, PNH, paroxysmal nocturnal hemoglobinuria. This is taken from pathoma. Also, I will discuss from USML inner circle and first aid. Okay, in PNH, there is acquired defect in myeloid stem cell. So there is what acquired defect in where myeloid stem cell, resulting in absent GPI, glycosyl inositol, glycosyl phosphatidylinositol, renders cells susceptible to destruction by complement. We know that blood cell, this is a blood cell, it coexists with complement. DAF, decay accelerating factor on the surface of the blood cells, protects against DAF, protects against this complement mediated damage. DAF protects against complement mediated damage by inhibiting how C3 convertase. By inhibiting C3 convertase. Okay, and DAF is secured to the cell membrane by GPI, which is an anchoring protein. If there is absent GPI, if there is an absent GPI, which leads to absent DAF, absent GPI, absent DAF, rendering susceptible to complement mediated damage, rendering susceptible to complement mediated damage. Okay, there is intravascular hemolysis occurs episodically, often at night, often at night during sleep, because we know that when we are in a sleeping state there is mild respiratory distress like hypoxia actually stimulates hypoxia. Decreased breathing during sleep activates hypoxia, actually activates what complement. And as there is no GPI, as there is absent GPI, so there is so as there is absent GPI, so there is complement mediated damage. So RBC, WBC are platelets are lysed. So there is intravascular hemolysis, which leads to hemoglobinemia, which leads to hemoglobinuria at morning. And hemosideruria is usually seen after hemolysis. Sucrose test is used to screen for disease, and confirmatory is and acidic serum test or flow cytometer to detect CD55 or 59 on the blood cell. Main cause of death, main cause of death, main cause of death is okay. Sucrose test is used to screen for disease, and we know that acidified serum test or flow cytometry to detect CD55 and 59 on the blood cell to confirm the diagnosis. And main cause of death is thrombosis of the hepatic portal and cerebral vein, hepatic portal or cerebral veins. Destroyed platelet release cytoplasmic contents into the circulation, inducing thrombosis. Destroyed platelet release cytoplasmic content, inducing thrombosis. And the complication is IgA due to chronic loss of hemoglobin in the urine and AML. So IDA and AML which develops in 10% of the patient. Okay, now from okay PNH. So in PNH, what happens in here? There is hemolysis. There is complement mediated hemolysis. That's why patient comes with the fatigue. Patient comes with the fatigue. That's why patient comes with the fatigue. And there may be cytopenia due to impaired hematopoiesis. There is cytopenia and venous thrombosis. Maybe hepatic portal venous thrombosis. So CBC shows hyperplastic or aplastic anemia, thrombocytopenia, and leukopenia. As there is bleeding, so increase LDH, low hepto. There is hyperbilirubinemia as RBC is breaking down hyperbilirubinemia, and hemoglobinuria, hyperbilirubinemia and hemoglobinuria, and there is absence CD55 and 59, and iron and folic acid supplementation as RBC is dying. So iron and folic acid supplementation, niculizumab, monoclonal antibody that against CD5 that inhibits the complement activation. Eculizumab actually inhibits the complement activation. Reason for increased thrombosis, why there is thrombosis due to venous thrombosis is caused by vasoconstriction and platelet aggregation as a free hemoglobin due to hemolysis and scavenging nitric oxide, a vasodilator, according to the prevalent hypothesis, activating endothelial lining of the blood vessels. So venous thrombosis is due to vasoconstriction and platelet aggregation as a result of free hemoglobin. Okay. mm, so now another important topic regarding this. Now G6PD, glucose 6 phosphate dehydrogenase. What is the likely diagnosis in an African American patient that presents with dark urine? African American patient presents with dark urine that stains positive with Prussian blue. Dark urine stains positive for Prussian blue after being treated for an UTI. If somebody has UTI and dark urine and stains positive for Prussian blue after being treated for UTI, it is G6PD. Positive stain indicates presence of hemosiderin. Positive stain indicates for hemosiderin in the urine due to hemolysis, and hemolytic episodes are often precipitated by infection and medication. Hemolytic episodes are often precipitated by infection and medication increase oxidative stress. What is the likely diagnosis? African American male that presents with dark urine, fatigue, jaundice after being treated with TMP-SMX. Peripheral blood smear show by itself, but a G6PD assay is normal. Okay, in G6PD deficiency, most erythrocytes with severe G6PD deficiency are hemolyzed early during the acute episodes. Thus, the G6PD assay may initially be abnormal and is best to wait for 3 months after the episodes before retesting. After the episode before retesting, there is hemoglobinuria. Heme is excreted in the kidneys, which can cause dark colored urine and false positive urine dipstick for blood. Hemoglobinuria, heme is excreted in the kidney, which causes dark colored urine and a false positive urine dipstick for blood. The heme in hemoglobin causes positive urine dipstick, but no erythrocytes seen on microscopy. What are the drugs that trigger hemolysis in G6PD? Most important is nitrofurantoin, primaquine, rasburic acid, isobutyl nitrate, and the dapsone. These are the drugs should be avoided, and the other drug should be used in caution, like acetaminophen. Look, acetaminophen is the OTC drug, but if somebody has G6PD deficiency, it should be used in caution. Aspirin, acetaminophen, chloramphenicol, chloroquine, colchicine, diphenhydramine, glyburide, isoniazid, L-dopa, sulfamethoxyl, trimethoprim, vitamin K. These are the drugs should be used in caution. Okay. Now in G6PD deficiency, it's an X-linked recessive disorder resulting in half-life reduced half-life of G6PD tenders to susceptible of what oxidative stress. RBC is normally exposed to oxidative stress, and glutathione, we know that glutathione is an antioxidant which neutralizes these free radical, which neutralizes this but becomes oxidized in this process. NADPH byproduct of NADPH is a byproduct of the G6PD is needed to regenerate this glutathione. If there is decreased G6PD, decreased NADPH, and reduced glutathione, there is oxidative injury, thus causing intravascular hemolysis. In African American variant, there is mildly reduced half-life of the G6PD lead to mild intravascular hemolysis. In Mediterranean, markedly reduced G6PD leading to marked intravascular hemolysis and frequency in high carrier frequency in both population, likely due to protective role against falciparum malaria. So they are playing an protective role against falciparum malaria. These are all about the PNH and the G6PD deficiency. Hope you enjoyed, and tell me the name of the murmur in the comment box. Okay, for the last time. Jazakallah khair.